Most behavioral health facilities don't have a referral problem. They have a referral concentration problem. One hospital system, one drug court, one primary care group, sending the majority of your admissions. That feels safe right up until it isn't. A new compliance officer, a competing facility, or one regulatory change can wipe out 30 to 40% of your admissions overnight. Diversification isn't a growth tactic here. It's operational risk management. Here's the playbook: 5 moves to build a referral network that holds. First, escape the single source trap. Networks stall for 3 reasons, and none of them are a lack of effort. They're a lack of structure. Concentration is first. When 2 partners drive most of your census, you are one relationship change away from a crisis. Second is inconsistent follow through. Referral sources remember exactly how fast you answered and how smooth the transfer was. One dropped call, one unreturned voicemail, one patient who arrives and is told there's no bed, and a relationship that took months to build is gone. Third is having no system. When referral development lives in one coordinator's head, it doesn't scale. Turnover takes the institutional knowledge with it. Second, map your referral ecosystem in tiers. Not all sources are equal in volume or durability. Tier 1 is high volume clinical partners, hospital emergency departments, ED social workers discharge patients daily who need structured care. Primary care physicians who screen for substance use disorder and need a reliable placement partner, and psychiatrists for dual diagnosis referrals. Tier 2 is community and legal. Drug courts and probation provide steady volume but demand specific documentation. Employee assistance programs, EAP counselors refer employees who often carry commercial insurance, improving your payer mix. And faith-based organizations where clergy actively seek trusted placement. Tier 3 is peer and alumni. Alumni of your own program are among the most powerful referral sources you have. Peer recovery coaches reach people before they're ready for treatment, and sober living operators create a natural step-down pathway. Third, build the clinical credibility that earns referrals. Sources don't just want a facility with open beds, they want one they trust to deliver outcomes and communicate clearly. Demonstrate competency through education. Host continuing education events for physicians, social workers, and nurses. Cover the ASAM criteria, protocol-guided withdrawal management, or the evidence on medication-assisted treatment. When a physician learns alcohol withdrawal staging at your facility, you become the credible expert and the natural next call. And make discharge communication a priority. When a hospital sends you a patient and hears nothing back, that relationship weakens. Close the loop. A timely, consented discharge summary separates you from competitors who never follow up. Fourth, nurture those relationships without burning out your team. Visiting every social worker and calling every EAP counselor is time-consuming. The answer isn't to do less. It's to build a system that does more with the same people. Segment your sources by tier and frequency. Your top 5 might warrant a monthly in-person visit. The next 20 get a bi-monthly email with outcomes data and bed availability. Your broader network of 100 plus gets a quarterly newsletter. Then make every touchpoint add value, not just volume. A clinical resource, a consented update on a shared patient, an invitation to your next education event. Outreach that only says we have beds, send us patients, erodes goodwill fast. The best referral relationships run on genuine reciprocity. You solve problems for the source, and the referrals follow. Fifth, track and optimize the pipeline. Referral development without data is just relationship maintenance, not optimization. Track referrals received by source. Track conversion rate by source. A high volume partner with low conversion signals a population mismatch. Track time to admission because friction is worth investigating. Track payer mix and track engagement. When did you last contact each partner and how many touch points in the last 90 days? Then build a quarterly review into your business development workflow: which sources grew, which declined, and where are the gaps. Use that to direct next quarter's outreach. Here's the bottom line. Building a network that consistently drives admissions takes 6 to 18 months of structured outreach. The most common mistake is treating it as a campaign you launch when census drops, then abandon when things improve. Sources notice. Technology doesn't replace the relationship, it determines how many you can maintain. HITJMS tracks every referral source, every touch point, and every conversion in one HIPAA-compliant platform. Visit hitjms.com and start a free trial today.